We can hear you. We
Okay.
can hear you great.
Okay, well, great. Well, first of all, I'm so delighted to be here, and thank you so much, Sarah, for inviting me to be able to speak to everyone about this topic, which is really important to all of us. I do want to apologize. My camera is not working, so you're seeing a stock photo, although you are hearing my voice live, and I'm sorry that you can't actually see me. But I'm looking forward to talking to you today about recognizing and managing late life depression. And I don't have any relevant disclosures to make regarding this topic. What I'd like to talk about with you over the next 45 minutes or so is I want to address, first of all, how common is depression in older adults? How is it diagnosed by psychiatrists and other treating clinicians? How do we treat it? And perhaps most importantly, how can we all help? How can all of you here today who are staff, maybe you have friends, their family, of your clients who you're concerned about, how can we help the individual who is suffering from depression? So let's start first with which might actually sound like a very simple question, which is, what is depression? And I want to be able to talk to you today, first of all, to recognize there really are different kinds of depression. Depression itself is not a homogeneous condition. It's not a monolithic condition. First of all, as you know, we differentiate in the field, of mental health between depression as an illness, from everyday depression and sadness. And that's really, it's kind of, in a way, unfortunate that the two terms are the same word to mean really vastly different kinds of conditions. So I have depression with a capital D, meaning it really is an illness. It's a concern from a mental health standpoint, versus depression with a small d, which would be considered to be probably maybe even a normal mood state or a more milder mood state. And usually it's something that's temporary. And it's a common feeling that everybody can relate to, where we've all had periods of time where we feel disappointed, we feel sad, something hasn't worked out. But it also can refer to more milder conditions of depression, such as the ones we call adjustment disorders, where there's a sad mood or responding to something that's happened in your life. Why do I call those depression with a small d? For me, as a psychiatrist, the biggest change between depression with a small d and depression with a big D is, can the person be cheered up? With adjustment disorders, as you know, you might be discouraged, you might be upset about difficult situations, a stressful family situation, personal situation. But even for a few hours, somebody can be cheered up by doing things that they enjoy. And hopefully with enough support of friends or peers, maybe other, sometimes professional staff as well, they can cope with it, improve their coping skills. Depression with a capital D, this is really a mental illness. And so I'm going to come back, and that's really what I'm going to be focusing on with you today. I also want to differentiate this from grief. And grief, again, a normal feeling. We all experience grief in the course of our lives. Perhaps our older patients have more of it because as we get older, there's more losses that people just experience. Friends, family pass away. There's losses related to giving up identity with work, or giving up identity when you can't because of a job or an illness that's affected you in terms of your functioning. I'm not going to talk about grief today, but I'm going to talk mostly about depression with a capital D, which usually means major depressive disorder. So what are the symptoms of late life depression that would indicate that this is a serious depression? Well, the way we diagnose depression in an older person is actually very much the same as we would do for any age. The DSM-5 does not have special or different criteria for diagnosing late life depression, but there are differences. And I am going to highlight them for you. First of all, the key feature that I look for as a psychiatrist is a persistent change in mood and or anhedonia. Most of the time, we think of depression as associated with a low mood, a persistently low mood of at least 2 weeks duration. However, in an older person, it might not be low mood. It might be more irritability, or more social withdrawal. We do see this kind of irritability in younger people too, but it's perhaps more common in older people. I've had many older patients that say they don't feel sad at all when they have major depression, and they may actually focus more on somatic, physical body complaints as the main problem. In fact, so this is, while we might see this in younger people, focusing on vague, multiple body complaints can be much, much more prevalent in the older patient with depression than the younger person. So for me as a psychiatrist, while I might be looking for, and I'll always ask my patients, how do they rate their mood? How would they describe their mood? I don't hang my hat on that in order to make the diagnosis of depression. And sometimes it's classic with sadness and tearfulness, but not always. However, I do always look for this, anhedonia. And I want to remind you, what is anhedonia? It's feeling a lack of pleasure and enjoyment in doing the things that were formerly very much enjoyed. If someone has been a sports fan their whole life, they no longer care what happens to the Ravens, what happens to the Orioles. If they are a grandparent, usually grandparents love their grandchildren. If they have a terrible late life depression, they might not want to be around the grandchildren. They might feel that the grandchildren are getting on their nerves. They don't get any pleasure from it. If they used to enjoy certain foods, they no longer get pleasure for it. So anhedonia is always there when there's a very, very serious depression. We also see a lot of self-deprecation, negative thoughts about yourself, feeling worthless, maybe excessive guilt. And the other thing that's particularly frequent in older patients are memory problems. The ones in blue we see in depression at all ages and in older patients. The ones in red are particularly strong in our older patients. So in older patients, we still see changes in sleep, classically difficulty falling asleep and early morning awakening, getting up at 2, 3, 4 in the morning, can't fall back asleep. Lack of energy, motivation, trouble concentrating. There might be recurrent thoughts of death, suicidal thoughts. I'm going to come back to this, and hopelessness, feeling like nothing is ever going to get better. But this one with difficulty concentrating can really present with more difficulty organizing your life that can be mistaken for dementia. So how common is depression in later life? And I hope I'm not going to confuse you by telling you that it depends where you look for it and what type it is. So that even in our older patients, I told you I was going to focusing on the more serious major depression. But look, I'm actually going to complicate this answer, make it a little more nuanced. This is very interesting that major depressive disorder, the way we think about it with the most serious form of depression, the rates among individuals living just in their neighborhoods and the communities, look how low it is. It's low. Why is that? We know that yet the rates are higher actually in medical patients who are hospitalized for medical problems in nursing homes. But there's this other condition in this part of the table where I've called it subsyndromal depression. And here the rates are significantly higher in community dwelling older adults, as well as in medical settings and in nursing homes. So what is this condition? Subsyndromal depression, sometimes it's called minor depression, sometimes it's called non-major depression. The key symptoms are exactly what you saw in the previous slide, a low mood and/or loss of interest in formerly enjoyed things, anhedonia, same as classic major depression. And in addition, there need to be 2 additional symptoms relating to appetite, weight, sleep, energy concentration, feelings of worthlessness, thoughts of death. When we as psychiatrists diagnose classic major depressive disorder, we're looking for 5 of these other symptoms. For subsyndromal, only 2. It's very interesting to note that actually subsyndromal depression is the most common mood disorder we see in older adults. And what we know about it is that you might say, well, it sounds like a milder form of major depression. In a way it is. We actually believe it is on a continuum with major depression, such that without any intervention, without specific treatment, 25% will turn into a classic major depressive disorder within 2 years. However, even at what seems like this lower level, it significantly impacts function, significantly impacts quality of life. And so we in psychiatry actually treat it the same way we would treat major depression. And it's reversible with similar treatments, which might be an intervention first, improving coping skills, psychotherapy. And if that doesn't work, we may actually use antidepressants, same as we would for more of a classic major depressive disorder. The most serious type of depression that we see in older patients is psychotic depression. And to just refresh your memory, when we talk about psychotic symptoms, we're usually talking about hallucinations and or delusions. Hallucinations being perceptions without a stimulus, seeing things, hearing voices and sounds that actually are not there. Psychotic depression sometimes includes auditory hallucinations, usually not visual, could be auditory hallucinations, but even more commonly are delusions. And again, to remind you, what are they? Delusions are defined as fixed, false, idiosyncratic beliefs, and all three elements have to be there, and they're very important. Fixed, meaning the individual holds on to a belief and you cannot persuade them. No evidence to the contrary will get them to drop the idea. False means it's patently not true. And idiosyncratic means it is particular to the person, meaning the belief is not part of a religious group, it's not part of a culture or an ethnic belief. It has to be something that is some sort of distortion or disturbance particular to the individual. What are the most common types of delusions we see in psychotic depression in older adults? Paranoid ones, somatic, which are bodily ones, and poverty. Delusions of poverty can be very, very common and very strong. The older adult might believe they're totally bankrupt. They're going to be out on the streets and be homeless. And even if you show them they have money in their retirement account, they have money in the bank account, they can meet, they have enough money to make ends meet, they will not believe it. The idea is so strong in their mind. Patients with bodily delusions can go to many different doctors because they're so convinced that they have something. Sometimes they have the absolute convinced idea that they have cancer. Or I had a patient who told me that he had not had a bowel movement in a long time. Now that is a common issue, right? Common in all of us, but particularly older adults frequently have constipation. And one might have thought, well, okay, he's older, maybe he doesn't eat enough salad or enough vegetables, he's constipated, okay. Until I asked the follow-up question and I said, how long has it been since you have had a bowel movement? And his response was 3 months. That's biologically impossible. Impossible. It actually was a delusion that he had not moved his bowels in 3 months. And interestingly, and this might surprise you, even when we admitted him to our inpatient unit, and of course he moved his bowels, and the nurses would show him what happened, he said, no, that's not from his body. And that's the power and strength of the delusion. Also, it's what often makes these kinds of psychotic symptoms are often not picked up by family members or by clinicians because they can seem plausible. They can seem real. If the patient says, I'm worried about money, I'm worried I don't have enough money, you might say, well, they're worried about money, they're being careful, they're frugal, or they're worried about their body. Until you really press and find out it's not a normal worry, it's actually a psychotic symptom and it's a delusion. Very important, by the way, to recognize that it's a delusion because it impacts the type of treatment. Well, what is the effect of depression on the older adult? Of course, there's emotional pain and suffering. The person is miserable. They're miserable when they're depressed. They don't enjoy anything. There's that emotional pain, and there's the additional aspect of a distorted view of themselves and the world. They're harder on themselves. They see nothing bright in the future, and that causes suffering. they're unable to function at the highest level they can be at this time in their life and enjoy the pleasures and that are there for them to enjoy in life. So there's a diminished quality of life. But there's more, particularly for our older patients, most of whom have coexisting medical problems. Anytime depression is coexistent with a medical problem, it always has a negative impact on the medical problem. How so? For instance, the older patient who has fallen, has a hip fracture, or has been hospitalized for a heart attack will have a much slower recovery. They tend to stay longer in the hospital after surgery or for any medical purpose. They tend to not adhere well to treatment recommendations. So say, for instance, an individual has had a serious heart attack. Well, you know, the cardiologist is probably going to recommend they take a low-fat diet, they do more exercise, maybe lose some weight. If they're diabetic, they need to watch their sugar. If they're depressed, they're going to have a very, very hard time, much harder following through on these kinds of recommendations, a harder time even taking medication correctly. So it actually makes the medical condition and recovery even worse. They have much higher rates of healthcare utilization for medical reasons. They're much more likely to go to the emergency room, to walk-in clinics, to urgent care centers, and to their doctors for all sorts of healthcare reasons if the depression is not addressed. And there's more. Depression increases risk for mortality. This is it's a pretty graph. It's a little complicated, but it's so important that I want to talk you through it so that you can understand it. What this is showing with all these different colors is these first three colors show survival curves for individuals who at the start of this 12-year period were cognitively normal. That's the red line. No dementia, no mild cognitive impairment, no depression. The next line here in the blue shows people who were cognitively impaired, had mild cognitive impairment, but weren't depressed. In yellow, individuals with dementia, but weren't depressed. Look at that. These first three all have better survival when there's no depression compared to these last three where there is depression. So even the patient with dementia, but no depression, had a better survival than those here in the green with no dementia, but were depressed. And the worst ones here in orange were those with dementia and who also were depressed. So here we see that depression impacts mortality. Depression also increases the risk for Alzheimer's disease. And we've seen this in a number of different studies. This is one study I'm going to show you where they followed individuals who, starting at the age of 50 and middle age, who had had a history of depression and mild cognitive impairment. So mild cognitive impairment often is a prodrome, could be an early warning sign that someone's going to develop dementia, but they don't have dementia. So they're followed up to 12 years. What they found is close to 42% who had had active depression within the past 2 years developed Alzheimer's dementia, compared to 32% with a more remote history of depression. Meaning, those who had had depression at midlife had a somewhat increased risk for developing dementia, but when it was a late onset depression, within 2 years of developing dementia, that seemed to be more associated. So our emerging understanding is depressive symptoms at midlife may increase dementia, but not as strongly as when we see particularly a new onset serious depression late in life, that those individuals are particularly at risk for developing dementia within 2 years. What we don't know is, are these depressive symptoms late life, are they part of the early feature, maybe at the very beginning, say, of Alzheimer's and the first symptoms, or is it that the two share some sort of a common cause? That we still don't know. So who is at risk for developing a late life depression? Well, as we see in younger people, if there is a positive family history, a first degree relative, which might be a sibling, parent, could be a grandparent, could be an adult child with depression. Yes, they're more at risk. But we also see many individuals who have a first time depression late in life, never had it earlier. Those individuals actually often do not have a positive family history, but they probably have had some sort of cerebrovascular event. So they probably have cardiovascular disease, high blood pressure, maybe diabetes. Those kinds of conditions increase risk for late life depression. If the person has had a previous episode of depression in their life, that increases the risk for depression later, even if that first episode was many, many decades earlier. For instance, perhaps the individual had an episode of depression in their 20s, but they were fine. In their 30s, 40s, and 50s, they are still at increased risk for depression later in life. Certain medications increase risk for late life depression, and ones that an older patient might be taking. They might be taking steroid medications for a variety of conditions. Beta blockers are commonly prescribed for high blood pressure. And then we also know social isolation, loneliness increases risk for late life depression. And we know, as we know, coming out of the pandemic, the coronavirus pandemic, so many of our older patients became much more socially isolated during this time. Depression and medical comorbidity go together because there are a number of medical conditions that are more common in older adults that are associated with high rates of depression, such as Parkinson's disease. Again, the rates go up with age. 40% of people with Parkinson's disease will get depression, up to a quarter of people with cancer. Stroke, very important, up to 30% of people who have a stroke will develop a post-stroke depression, and the risk for depression after a stroke is heightened up to 2 years after the stroke. It is particularly strong in the first 3 months. I'm going to remind you, you might remember from the news, I think even earlier this summer, a very well-known senator from Pennsylvania, John Fetterman, had a stroke in I think late spring. And then he developed a serious depression. And I'm mentioning it because this was in the news, and it was, I give him a lot of credit for being disclosing it and sharing it. He actually was hospitalized, had a psychiatric hospitalization for major depression. He developed a post-stroke depression, this famous senator from Pennsylvania. Up to 20% of people with Alzheimer's get depression, and it's even increased in diabetes, probably because diabetes, we think of it as a problem with blood sugar, which it is, but diabetes affects the small blood vessels, and something about that they affect circulation and cause increase in cerebrovascular disease. I want to say a couple of words about suicide in older adults. You should know, and you probably know, suicide rates are very high in the elderly, and most of this is attributable to men whose risk increases with age, especially Caucasian white men. Among people over the age of 65, men account for 85% of the suicides. When we look at suicide in later life, a couple of aspects are particularly strong risk factors. One is any previous attempt in the past absolutely increases risk for a completed suicide, and also having a chronic depression that doesn't get better and having hopelessness that doesn't get better are also serious risk factors. We know that among all ages that younger people make more suicide attempts. Among the elderly, there is 1 completed suicide for every 4 attempts. So meaning they make fewer attempts, but they're more likely to have a completed suicide. And why is this? Because most geriatric suicide is due to firearms more than any other age group. Younger people are more likely to have an overdose, which you can miscalculate on, even if you are trying very hard to kill yourself. Whereas an older person is more likely to turn to a firearm and therefore more likely to have a completed suicide. Now, a lot of older people these days, why would they have a gun with them? So Some, particularly in rural areas, might have been hunters, and so they keep a gun for that kind of purpose. Many of our older adults worry about crime. They worry about their safety, so they keep a gun in the home for those reasons. It's very important when you're treating an older person who is depressed to find out if there is a gun in the home. And one of the first interventions I do is ask a family member to take the gun out of the home so that there would not be this chance of it being used in a moment of desperation, which can happen and can come on even suddenly. What makes suicide assessment in the older adult a little more difficult is that many older adults do think about death, but not in a pathologic way. So as we age, many of our older adults, they're thinking more like, well, there's fewer years in the future than there is behind them. You know, with every age, you think, well, I don't have many more years to go. They're thinking about their parents, so maybe they are achieving the age where a parent passed away or a sibling passed away or other friends are passing away. So thoughts about death in older people is not always a sign of suicidality. It can be normal. It could be non-pathologic. It could be reflective. And I think this makes it a little tricky to try to think about, well, what is the context of these thoughts? And particularly when I am teaching our young doctors and young psychiatrists, I have to teach them they have to get comfortable talking about death with older patients and being able to distinguish between what are normal thoughts and what are more worrisome thoughts. So an older adult, for instance, who reads the newspaper might turn to the obituary page to find out if there are people they know from church or the neighborhood have passed away and they want to know about it and maybe go to the service. That would not necessarily be a sign of suicidality. Thoughts about death, meaning wanting to die, that's a different matter. And we distinguish between passive death wishes, which is saying, if the Lord would take me tonight, or if I were to pass away in my sleep and not wake up, I'd be good with that. That's a passive death wish. That's wishing that your life would end, but not thinking about that you will do anything to end it. That's less worrisome, of course, than someone who has active thoughts. And if anyone is having active thoughts, thinking that they would actually consider something that could shorten their life or end their life, and they have plans for self-harm, that requires intervention. And so if you are concerned about an older person who may have suicidal thoughts, you must distinguish, well, are you thinking about this? Are you thinking that you would be okay if you would pass away in your sleep or not be alive tomorrow? Are you thinking of that something you might actually do to harm yourself? And then you must follow. And if they say yes, you must follow up and find out, well, what are you thinking of doing? Do they have the means? Are they thinking about pills? Have they practiced it and looked at the bottles? Have they been hoarding the pills? Are they thinking about other kinds of ways they might harm themselves, and do they have the means? And you must take some form of intervention at that point. Again, in terms of thinking about who's at risk, any knowledge of a past attempt, even if it was decades earlier, increases risk. Other risk factors, as I mentioned, is depression, especially a chronic depression that doesn't get better, being isolated, widowhood, being separate, no longer having a partner with you, alcohol abuse increases risk, and having chronic physical illness and pain. I want to say a word about dementia and suicide. So as you know, as we have an aging population, which we do in Maryland, in the United States, and in the world, we are seeing increasing numbers of individuals with dementia of all types, and of Alzheimer's is the most common type. So the question has come up, well, is dementia a risk factor for suicide? Trying to predict suicide is difficult to do. You might think theoretically, well, if the individual has insight into their disease, this could increase risk for hopelessness, but you might say, well, maybe dementia decreases risk because the individual has a diminished cognitive skills, and as they get more impaired, they have more supervision. And actually, both are probably true. So much more advanced cases of dementia, we really don't see a higher risk for suicide. However, and this is very worrisome to me, which is that we are seeing an increased risk of suicide and suicide attempts in individuals who have been recently diagnosed with both either mild cognitive impairment or with actual dementia. And this is a couple of studies are now demonstrating this. And this one is from looking at VA veterans medical centers in the United States. It was a very big study, many thousands of individuals. And what they found is those individuals who were recently diagnosed with mild cognitive impairment or dementia were at increased risk of attempting suicide. And the risk seems particularly strong within the first 3 to 6 months. This has me really concerned, as I said, as a geriatric psychiatrist, particularly because we are now at the point where people can get blood tests that show them that they are at risk for dementia even before they have it. And I think it's one of those situations where we have the technology with not all the safeguards in place. Just because someone can get the blood test, they need to have the counseling to put it in perspective, and perhaps the support to recognize and appreciate that a diagnosis of mild cognitive impairment or dementia isn't the end of the world and isn't the end of their life before they do something drastic. So this would be a discussion for a whole nother, really a whole nother hour, but I did want to let you know that this is a concern because as you might be seeing clients who have been recently diagnosed with mild cognitive impairment or dementia, we do need to be concerned about whether they might be at increased risk for suicide. So with all of this, why is it so difficult for clinicians to recognize depression in older patients? Sometimes it's hard because the patients, for instance, don't necessarily say they have a low mood and they're not sad. They go to the doctors, their primary care doctor, with a lot of physical complaints. So that becomes the focus with the primary care clinician. And in fact, when there's a lot of other medical comorbidity, it can be hard for the primary care doctor to appreciate it. In a young person in their 30s who says that they're too tired all of the time, they're not sleeping well, they don't have a good appetite, they can't concentrate, they've lost pleasure in things, well, depression's going to be higher on the list. An older person who has the same symptoms, the doctor's going to be thinking about all kinds of medical conditions first, possibly, and depression may not be at tops on the list. And then there's this aspect that I mentioned earlier, that many older adults have cognitive impairment that mimics dementia, but it's not the same cognitive impairment as Alzheimer's. Alzheimer's is a condition of quick forgetting of short-term memory. When people have depression and it's an older adult, they have trouble with executive functioning, meaning they have trouble organizing, planning. So even things like shopping, organizing their bills, paying their bills, planning meals, organizing their medications, they're going to have difficulty with. What about treatment? The very first thing is patients who have serious depression need treatment. One of the biggest problems I see is not being prescribed an antidepressant. So often, if depression occurs in the setting of some sort of disappointment or trouble or stress, you might say, well, you'd be depressed too. I call it the you'd be depressed too problem. So a family member or a primary care physician might say, well, you'd be depressed too if you had to downsize your home and you had to sell your home and you had to move into an apartment or a retirement community, you'd be depressed too. If you had to retire due to your medical problems and you always enjoyed your job, you'd be depressed too. If your children were having trouble and you were worried about them. Just because it's understandable doesn't mean it's not a serious depression. We know this, in mental health and psychiatry, but sometimes our clinicians don't. Also, insufficient dosing. When older patients are prescribed medication, we always start at a low dose, but just because we start at a low dose, we don't finish at a low dose. The final dose is usually the same as younger patients, but I often see patients with older patients being underdosed. I often see the older patient themselves mistaking side effects. What they think are side effects are actually the symptoms for which the medication is for. For instance, anxiety, it goes along so often with depression. Sometimes the bottle says this, a possible side effect is anxiety, and they say, oh, my anxiety is due to the medicine. And that's a misunderstanding. I think it's important to keep in mind, I think for all of you listening, that one of the things that I notice and that you should be aware of, and I educate my patients and families about this, is that we see a diurnal variation. What that means, and this is very, very classic for serious depression, that the symptoms tend to be worse in the morning and get a little better as the day goes on. Diurnal means daily. This change in mood and symptoms is common and is one of the hallmark features of a major depressive disorder. Why is this important? It's important because what I often tell patients is what they're going to notice when they get better. For instance, with medication, is sort of a counterclockwise improvement in well-being. Instead of feeling a little better at 7 p.m., it'll be then 3 p.m. And the last part of the day to get well is the morning. And that's important to know because, say, for instance, the individual takes their medication at night. Then they wake up in the morning feeling really crummy. They say, oh, it must be due to the antidepressant, and they stop the medicine, not realizing that this daily variation in mood is a symptom of depression. Also, that huge list of symptoms that I showed you, which I refer to when I'm making the diagnosis, while I'm looking for many of them to be there at the same time to make the diagnosis, they all don't improve at the same time or the same rate. Very important to know this. Early symptoms that improve are energy, sleep, and appetite, but well-being, feeling good, and mood, it's ironic and it seems unfair, but this is the way it is. That's one of the last symptoms to return. So very often you as a helper, as a staff member, as a clinician, or a family member might say, gee, this person seems to have a little more energy. They seem like their appetite's getting better, but they still feel lousy. That's normal in terms of the recovery from depression. Medication is not always necessary. I think particularly more minor or early forms of depression benefit from things I'm going to emphasize even more later. Exercise, activity, structure, getting a good night's sleep, so important. And supportive psychotherapy, so important to getting people and getting them well, and may improve their well-being without needing antidepressant medicine. But antidepressant medications are appropriate for most people, in combination with psychotherapy. And yes, as you know, we do ECT, electroconvulsive therapy, for the most serious forms of depression. ECT, in fact, is the most effective treatment for psychotic depression, depression with those delusions that I just spoke about earlier. What about antidepressant medicines? So in 2023, we have a lot on the market. All of them work. They don't all work for everybody. And so sometimes it can be a little bit of trial and error. You start with one. Usually in our older patients, we're starting first these days with an SSRI, a selective serotonin reuptake inhibitor. But if it doesn't work, there are a lot of other ones we can add in addition or switch to. So we have to find the one that's going to work for the person, and they have to have an adequate trial. Although we have so many more medications on the market than we did 30 years ago when I first started practice, none of them work quickly. So they all take 4 to 6 weeks once you get to an adequate dose to get the most effective results. And of course, by the time somebody is starting treatment, when do they want to feel better? Well, last week. It's very hard, to continue to feel depressed for 4 to 6 weeks more. And that's where peer support, family support, staff support is crucial. So in the early weeks, the approach is usually a selective serotonin reuptake inhibitor, usually at a low dose, but increasing it gradually. There are side effects of this class of medicine. If it causes some upset stomach, usually that can be tolerated. A mild hand tremor can be common. If it causes severe diarrhea, then we switch to a different type of medication, and occasionally it causes a condition called hyponatremia, where the sodium level goes low, and then usually that requires a switch in medication. There have been great studies that actually show antidepressants reduce the risk of suicide among elderly and depressed patients, but you should also know that that because it is such a heterogeneous disorder, the antidepressant response rate isn't as great as we'd like to see. And usually less than 50% of the people really get well, fully well on the first medication we try, which means it really needs a professional. They need to work with a good psychiatrist or good primary care doctor. If the first medicine doesn't try, not to give up. We might add another medication for augmentation. We might switch classes of medication altogether. This condition of executive impairment is so important to recognize. For one, it's important to know it doesn't necessarily mean the patient has dementia so that you treat the depression, but also because there might be an impact on daily functioning. The individual has trouble cooking, managing finances and medication. Maybe somebody else needs to take over. Maybe it's a spouse or a partner or an adult child. And maybe you need to come up with strategies to help them to take their medication so that they don't make mistakes. About psychotherapy, there have been research that shows that cognitive behavioral therapy, interpersonal therapy, and supportive therapy are all effective in older patients who have depression, and they all, it's a matter of choice and what's available. And again, ECT can be extremely effective. Usually we started as an inpatient here at Johns Hopkins, but we might continue it as an outpatient. We have to be more careful with older patients because it can cause confusion, which is temporary, but there have been many studies now showing it does not cause dementia. It does not cause persistent, long-term confusion. And so that people do recover, and we can be very reassuring about that. What else is helpful? Well, again, some sort of regular exercise, aiming for 7 to 9 hours of sleep, being with family and friends, and having some sort of structure and routine. This is often counterintuitive to the older patient who may feel like, well, when I get better, I'll go to church. When I get better, I'll go back and do the things that I used to do. But we in psychiatry know that behavioral activation, which is structuring, planning, and committing to doing activities, actually helps people come out of depression faster. So they need to be involved and push themselves to some degree to do things even before they feel fully well enough to do them. And that behavioral activation and getting busier and being socially connected can be very powerful in assisting with recovery. What about other treatments on the horizon? Well, you know about TMS, transcranial magnetic stimulation. It is I would say right now, the evidence is not great yet that it's really effective in older patients with depression, but maybe we'll have a better idea in the next couple of years of, are there more subgroups of older people who benefit? TMS has the positive side about it is does not cause confusion the way ECT does. It is not as effective as ECT. So for somebody who has a very severe form of depression, TMS usually is not going to be helpful for them. Esketamine is approved for treatment-resistant depression, is delivered intranasally. It is a form of ketamine, which is an anesthetic. Again, we don't yet have good studies to show how safe or effective it is in older patients, but some of my older patients have been able to get esketamine. And again, we don't use it for mild or even moderate or even severe forms of depression, but right now we're only turning to it for really treatment-resistant depression. There's a lot of attention really to developing medications focused on different brain chemicals and ones that work faster. And esketamine may be one of those, but again, there are there are other things that are being looked at in the pipeline, and I hope in the next few years we have even more in our armamentarium of treatment to offer our older patients. What about stigma? This is a real concern for us in mental health. As you know, at all ages, it's a particular concern for older patients. I think, I'm seeing, and you're probably seeing as well, that younger people in general, I think, are more open to getting help and being honest about mental health symptoms. But our older patients grew up in a different era, and they often feel embarrassed. They could blame themselves. They might have self-reflected ageism, where they themselves might feel, well, I'm just getting old. And so, this is just a feature of being old. Or their family members may have ideas, well, they're getting old. What would you expect? I really see this as a form of ageism. And just because someone's old doesn't mean that they deserve to be depressed, or we don't want to treat their depression. But feeling embarrassed or misunderstanding that this depression is a real illness can prevent somebody from getting the help that they really need. So how else can staff and families be of help to an older adult who is suffering from depression? Well, I'm going to tell you that I would like you to encourage their activity. You're going to have to sort of walk a bit of a fine line between wanting to be encouraging, getting them connected, engaging them in this behavioral activation without being overly pushy as they're getting better. You want to encourage hopefulness and patience. Absolutely. Tell them you've seen this before. You know this is a treatable condition. They are going to improve. You have to tell them recovery takes time. It's also important to recognize it's not linear. I often tell my patients we all wish that recovery would be like going up a staircase each day, better, 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 better. Where in point of fact, that almost never happens. It's usually more of a zigzag. 2 steps forward, a half a step back, then another step forward. I think that's really helpful to let them know that if they have a really great day followed by a day that's not great, it doesn't mean that the medication isn't working or they've become immune to it. That's normal. So as a psychiatrist, I actually look for improvement on a weekly basis rather than day to day. And say, well, I expect next week should be better than this week. And the week after that will be better than next week. And also, you'll recognize that irritability, snappiness, that the individual not being as patient, those are symptoms of illness. Remind your family members, don't take it personally. If the older person is more negative, more irritable, less patient than their normal self, this is part of the depression, part of the illness. It's not a permanent personality change. So really the summary again is depression in later life is common. It undermines health and well-being. There are many treatment options available. They take time to be fully effective. And again, to emphasize, depression in later life is never a normal part of aging, always should be treated. So thank you all very much. And I'll stop and take some questions. I'm sorry that I know that it's gone on a bit longer than I had hoped.
No, that's great. Thank you so much. Yes, we do have about 5 more minutes left with our time together. Again, thank you so much for this conversation. And yeah, I think that last point, that dementia is not a normal part of aging. Thank you so much for that reminder.
Depression.
Yes, yes. Any questions today? Feel free to put them in the chat or go ahead and unmute.
I have one question. This is Carol from Connecticut, New Horizons.
Great, absolutely. Go ahead.
I've have heard of having DNA testing be done to be able to better match you up with medications. What's your sense of that in the world of depression and elderly, et cetera?
Yeah, That's a really good question, and you're right. There are a couple of companies actually that market tests that say that they can show which medications are more likely to be effective. To be truthful, I never use them myself because I really don't find them to be as have good predictive value as they say that they do. So they're talking about that they focus more on something called pharmacokinetics, which is how your body might, sort of how the body might metabolize or digest the medication, but not the pharmacodynamics, which is how does it really work in the brain? And that's really what we want to know. How do they really work in the brain? So as I said earlier on, we know that all medications work for someone. They all don't work for everyone. What I find in terms of DNA to be a better predictor is if the individual has another family member, if they have a brother, a sister, even a son, a daughter who has been treated for depression and had a great response on a particular medicine, I'm more likely to turn to that for my older patient because what works for a family member might work for them. But I don't find those genetic tests to be helpful and good predictors.
Thank you.
We have a question here in the chat that says recently postpartum depression has a new drug that is working quickly for new mothers. Is this something that older persons could use to have a quicker result?
Yeah, that's a great question. In fact, yesterday I actually just even was listening to a podcast about this new medication. Brexanolone was the IV version of it, and now it comes in an oral form. It would be great if we had something like this for older people. No one has tried this medication in older patients. I'm not hopeful that it will because I think there's something really different about postpartum depression and its use that really relates to the hormones of pregnancy, which is and that's what the treatment is really focused more on, kind of hormonal changes that seem to be more particular to women at this time of life.
And another question here, how do you address somebody who feels that antidepressants will impede their driving?
Okay, so I'm assuming that you're wondering whether an antidepressant is going to make somebody drowsy or sedated. And there are a couple of medications that are given at night that might make somebody a little bit drowsy in the morning, but most of the antidepressant medications do not do that. So I would not think that there would be an impairment on driving from a non-sedating antidepressant. There are plenty of medications that would not. I will say being depressed will impede driving because if somebody is depressed, there is a condition called psychomotor retardation and difficulty with decision making. So the person might have a slower reaction time, be less aware, less able to concentrate and focus, and having an untreated depression probably puts them more at risk for driving impairment.
Okay, I don't see any other questions in the chat. Is there anyone else that would like to unmute? Great. Well, we're about 30 seconds away from 12:30, so we will go ahead and end our time together today. But again, thank you all so much for joining us. Thank you for this wonderful presentation. We will certainly be sharing this recording after this afternoon. And again, we will resume at 12 o'clock next month on October the 18th. So we'll see you again for our housing happenings in October, again, at our regularly scheduled time at 12 o'clock. So hope everybody has a great rest of the day.
Thank you. And thank you all for accommodating my schedule and coming earlier. And I will just add, if anyone has any questions they want to send to you, pass them on to me. I'd be happy to answer them by email.
I absolutely will do that. Thank you so much.
Okay, bye-bye.